Let's be honest, a single enlarged lymph node in the neck, just sitting there on its own, is probably one of the least alarming things you can find in medicine. Most of us have felt one at some point after a sore throat, right? We just ignore it and move on. But if you find that exact same node alongside another one in the groin and another in the armpit, plus a spleen you can physically feel below the ribs, well, the medical mystery you're trying to solve has just completely shifted. It's not because that individual node suddenly morphed into something more dangerous. It's because of what finding them in multiple places at once actually tells us about the body. Welcome to this explainer, where we're going to break down lymphadenopathy entirely from first principles.
Right, let's dive right in. What actually changes when one node becomes several? To really get lymphadenopathy, you have to look at lymph nodes for what they essentially are, the body's regional checkpoints. They are literally built to sample and react to whatever is happening in the specific tissue they drain. So, figuring out what triggers just one of these checkpoints versus what sets all of them off at the same time is absolutely key to everything we'll cover today. Section 1. The body's regional checkpoints. Let's start with the basic anatomy here. Each lymph node group drains a very specific anatomical territory. Think of them like border guards. They sample the lymphatic fluid from their assigned region and mount an immune response to any antigens, whether they're infectious, inflammatory, or malignant, that just happen to be passing through. For instance, the axillary nodes. They're the checkpoint for the arm and breast on that same side. Inguinal nodes guard the lower limb and genital area, and your cervical nodes handle drainage for the head, neck, and oropharynx. So when you see localized lymphadenopathy, meaning enlargement confined to just one node group, it points you directly to whatever that specific territory is draining. It's just a localized checkpoint reacting to a local exposure. But generalized lymphadenopathy? That is an entirely different beast. This means you are dealing with a systemic process. Something is circulating throughout the patient's entire body and triggering multiple independent checkpoints all at the exact same time. Your question fundamentally shifts from what's happening in this one spot to what on earth is circulating everywhere. So what is the official threshold for that systemic shift? Well, here is the precise 2025 medical definition you absolutely need to commit to memory. Generalized lymphadenopathy is enlargement in two or more non-contiguous node groups. That specific threshold fundamentally changes your whole mechanistic differential. The second you confirm nodes in two non-connected regions, you are completely off the local pathway and strictly on the systemic one. Section 2. Reading the physical clues. Before you even start running down your list of possible diagnoses, you should know that the node itself has a story to tell just by the way it feels. The physical characteristics of a single node can dramatically shift your diagnostic probabilities right there at the bedside. Reactive infectious nodes are classically soft, tender to the touch, and mobile under the skin. They wiggle around. Malignant nodes trend toward the exact opposite pattern. They're often firm or even rock hard, completely painless, and fixed to the surrounding tissue rather than moving freely. But, and I really want to emphasize this, while these are genuine, highly useful patterns, no single physical characteristic definitively rules a malignancy in or out on its own. They're just clues, not verdicts. Since they're just clues, the crucial part is knowing what other signs to look for. Size definitely matters. Nodes larger than 1 centimeter in the cervical or axillary regions, or larger than half a centimeter if we're looking at the epitrochlear or inguinal areas, are officially crossing normal size thresholds. Then you have matting. This is when several nodes literally fuse together into a single, irregular mass. If you feel that, it significantly raises the concern for a malignancy, or, especially in kids, granulomatous disease. And finally, always ask about B symptoms, fever, those drenching night sweats, and unintentional weight loss. If you see those alongside enlarged nodes, your suspicion for lymphoma or another underlying cancer needs to shoot way up. Section 3. Localized versus generalized disease. Let's move to our next core concept and see how this actually builds into our systemic differential. We're focusing on the specific underlying causes that drive generalized lymphadenopathy. If we organize this by mechanism, 4 main buckets emerge. First is malignancy. So we're thinking lymphoma, both Hodgkin and non-Hodgkin, leukemia, and less commonly, metastatic carcinoma or Kaposi sarcoma hitting multiple spots. Second is infection. This spans everything from bacterial causes like syphilis to mycobacterial like TB, down to viral, fungal, and parasitic infections. But keep this in your back pocket. Epstein-Barr virus, or EBV, which drives infectious mono, is genuinely the most common cause of generalized lymphadenopathy you'll encounter in everyday practice. Third is autoimmune disease, primarily systemic lupus erythematosus, or SLE. And fourth is this fascinating miscellaneous group. We're talking sarcoidosis, Kikuchi disease, drug reactions from meds like phenytoin and allopurinol, and even storage diseases like Gaucher and Niemann-Pick disease, which infiltrate the reticuloendothelial system. Now picture this. A patient presents with pallor, bilateral firm, rubbery, painless, mobile lymphadenopathy, plus an enlarged liver and spleen, hepatosplenomegaly. You absolutely have to view this as a single clinical gestalt. Do not work up the nodes and the spleen separately. Together, they indicate a disease process that is capable of infiltrating both the reticuloendothelial system and the lymph nodes at the exact same time. This presentation practically screams a myeloproliferative or lymphoproliferative infiltration. Recognizing it as one combined unit is exactly what gets you to the right differential efficiently.
Section 4. The Virchow's node trap.
So while recognizing those systemic patterns is absolutely crucial, sometimes a single, specific, localized node can be the most dangerous finding of all. Let's look at the named superficial node groups, like the submental, jugular, and posterior cervical nodes, and zero in on the one that carries the absolute highest diagnostic weight. Which brings us to this quote. I absolutely love this, because it perfectly captures the trap. Think abdominally and pelvically, not cervically. We are talking about Virchow's node, which is specifically the left supraclavicular node. Out of all the node groups you can examine, this single one carries the highest probability of malignancy. And the reason for that is entirely anatomical. If you feel an enlarged left supraclavicular node in a patient without an obvious local cause in the neck, it should immediately prompt you to look down at the abdomen and pelvis.
Here's exactly why Virchow's node is such a wild anatomical trap. This specific node receives lymphatic drainage directly from deep thoracic and abdominal structures via the thoracic duct. That means its enlargement is a direct signal from the abdomen, completely bypassing the neck altogether. It classically signals malignancy originating from places like the stomach, gallbladder, pancreas, kidneys, testes, prostate, or ovaries. An enlarged checkpoint here is basically waving a massive red flag about a fire burning deep inside the body.
Section 5. The 2025 Diagnostic Guidelines.
So, how do we pull all this theory together into actual practice? Let's walk through the current 2025 Comprehensive Review's structured approach to unexplained lymphadenopathy. This number 4 is highly practical. The 2025 guideline plainly states that for localized nodes where your history and exam leave you with a low suspicion of malignancy, the absolute best approach is a 4-week observation period. Most localized lymphadenopathy is totally benign and self-limiting. Rushing into unnecessary early biopsies just adds real financial cost and medical risk to the patient. Just give it 4 weeks. This matters because quite often, watchful waiting is the most sophisticated clinical decision you can possibly make.
Now, generalized lymphadenopathy, on the other hand, consistently warrants an active workup. Think full blood counts and HIV or EBV screens, given that higher likelihood of systemic disease. But here is the critical procedural takeaway from those 2025 guidelines. If malignancy, and specifically lymphoma, is a genuine concern, an excisional biopsy firmly beats a fine needle aspiration, or FNA, hands down. The problem with an FNA is that it frequently provides insufficient tissue architecture to definitively characterize a lymphoma. The excisional biopsy remains the absolute diagnostic gold standard because it preserves that crucial tissue architecture intact for the pathologist to actually see the whole picture. And that brings us right back full circle. Breaking down lymphadenopathy from first principles isn't just about rote memorization of diseases. It's really about understanding the underlying logic of the body's checkpoint system. So the next time you encounter an enlarged node, I challenge you to pause before jumping straight to a diagnosis. Ask yourself, is this just one checkpoint reacting locally, or are multiple checkpoints flagging a massive systemic process all at once? Let that single distinction be your primary guide. Thanks so much for joining me on this explainer, and I really hope this transforms how you approach your next clinical mystery. Catch you next time.